Today we have Dr. Mahmoud Taha, who will talk about the new WHO classification of CNS in pediatric group. Thank you very much, Dr. Taha, for this contribution to our continuous education. And we can start now with your presentation.
Okay, so we're going to start now. Bismillah ar-Rahim. So this is the second part of our talk. Last time we covered the adult overview of updated WHO classification of brain tumor in adult. Now we're going to move to pediatric. Okay. Again, I would like to thank the scientific committee in SANS for giving me this opportunity to participate in this platform. This is the outlines of the presentation. We will start with introduction, overview of pediatric brain tumor in general. We'll give summary of the new WHO classification of CNS tumor in children, and then the overview of new updates and molecular diagnosis of common pediatric brain tumors with case presentations. And I have nothing to declare. We'll start first with the common types of brain tumors in children, and you can see the variation in the types of brain tumors between studies, between countries. So astrocytoma account for the majority of brain tumors in children, between 30 to 40%. Medulloblastoma, I would say between 10 to 20. It's recognizably here, it's highest in the Middle East, and I think we probably have similar incidence as well. It's medulloblastoma is slightly higher in this region. Others, ependymoma number 3, between around 7-8%. Craniopharyngioma is a good percentage, between 6.6 or 4 till 11. Choroid plexus, not very common. Germ cell tumor, remember here, it's very common in Southeast Asia, in Japan and Korea. Okay. So important to recognize the difference in variation in the type of brain tumor between countries. And in general, brain tumors in kids is the most common solid tumor in children. But it is second following leukemia. But if we talk about solid tumor, it's number 1. And it's leading cause of cancer death in individuals between 0 and 19 of age in the US and Canada. Incidence in countries, it's again variable, like the subtypes, it vary from 1.1 to 5 per 100,000 per year. The highest in North America and the lowest in Middle East, according to a lot of studies. Now, if we talk about Saudi, according to the Saudi Cancer Registry, number 1 is leukemia, 34.6%, followed by brain tumor. So it is second, like the rest of the world, 15% of pediatric brain cancer. So we're talking about cancer here. Okay, remember, pediatric cancer is about half of the tumor. The rest, the other half, is considered benign. The 2014, there were 104 cancer cases in children and brain cancer. And we estimated it's about 0.5 per 100,000. But remember, the cancer registry in Saudi include kids below 15. Some cancer registry in Western country, they go up to 18. And we mentioned last time the problem with the cancer registry. They only include cases that have pathology, and the pathology they used based on the ICD system, not the WHO system. So again, we will go through the this table again. We went through it in the first presentation in adults, and this is just a reminder of what we covered last time. We went really in details about this, the diffuse astrocytoma and glioma in adults. And you can see now they are classified according to the IDH-mutant, wild-type, So we have the diffuse cytoma, anaplastic cytoma, glioblastoma, oligodendroglioma. Again, this is when you have the co-deletion and the IDH mutant at the same time. This tumor, diffuse midline glioma, H3K27M mutant, this is a new entity in WHO classification. And I did not cover this last time, but we will cover in detail this time. It's a very important entity, and it has to be understood by all the residents and neurosurgeon and to appreciate this new classification. It's going to be discussed in details. Okay. Now, pilocytic astrocytoma, we didn't cover it last time because it's mainly in kids. And we have the pilocytic subependymal giant. So we call this group the BRAF family, if you remember. So this is, we call it the IDH family. This is the BRAF family. Okay. Again, we will discuss this in details, the pilocytic astrocytoma and the low-grade glioma in pediatric population. Ependymal tumor, again, we have 3 grades from different subtypes. We will also cover them. These tumors are rare, and there's nothing changed actually in the new classification. Pineal, same thing, nothing new, so we will not talk about it. Embryonal tumor, obviously, it is major changes, especially medulloblastoma and the non-medulloblastoma tumor. These are rare, but we will talk about them as well. The rest are, there's no major changes in pediatrics. Last time we talked about meningioma and new change in atypical meningioma classification. But these are the major brain tumors that we will be covering in this presentation. Now, this slide will summarize all the major changes in the WHO classification of brain tumors in children. Remember, it's still, low-grade glioma, high-grade glioma, medulloblastoma, embryonal tumor, ependymoma. These are the most common ones. Low-grade glioma in adult is diffuse astrocytoma grade 2 or diffuse oligodendroglioma, as we all know that. Low-grade glioma in children, it's pilocytic astrocytoma. Majority of low-grade are pilocytic. Okay, so when you say low-grade glioma in children, we're talking about pilocytic astrocytoma, and these are the rest of it. So diffuse astrocytoma, oligodendroglioma grade 2 are not common in kids because these are adult tumors. Okay, these are the pediatric tumors, low-grade, but we still call them low-grade glioma. Okay, so this is again BRAF mutant family. This is the one we talked about last time, and we will go through them. Now, high-grade glioma in children, the major change here is this: the discovery of the midline or this is a new entity, but the renaming, if we can call renaming, of an old tumor. Midline glioma, the K27, with the new subtypes that was discovered, we will cover them later. This is the new changes. So we still have the glioblastoma, the midline glioma with its subtypes, again, will be covered. So anaplastic astrocytoma, anaplastic oligo, the IDH mutant, these are the common one in adults, are rare in children. Okay, so when we say high-grade glioma in kids, we are talking about glioblastoma, midline glioma with the different subtypes. Okay, so remember, low-grade glioma in children is pilocytic, pylomyxoid, PXA, Sega, ganglioglioma. Consider actually it's a mix. It's a astroneuronal tumor, but they found it has molecular aspects similar to the pilocytic astrocytoma. That's why it's been included in the low-grade glioma in children. Okay. Now, major change. This name, DIPG, which is diffuse intrinsic pontine glioma, it's been removed now. Okay, so we don't call brainstem glioma. We don't use this term, brainstem glioma or DIPG. It is replaced by midline glioma. Okay, so, and we'll explain why. Okay, in the next few slides, we'll tell you why we are not saying DIPG anymore, and we have to call them midline glioma now. Okay, so that's the major change. Medulloblastoma, the new changes is the 4 subgroups of based on molecular pathways, and they have 14 subtypes now. Embryonal tumor, again, we have the C19MC altered entity. Again, another major change, no more peanuts. Okay, the peanut, as we used to be told about is the medulloblastoma outside cerebellum. Again, this term is being removed. Okay, no more peanut, no more DIPG in the new WHO classification. So this is similar to what we said in the adult tumor. Remember, we have 2 entities has been removed. The gliomatosis cerebri, no more, it's multifocal. And oligoastrocytoma, no more, it's either oligodendroglioma or astrocytoma. Same thing here, we have 2 entities, which is very commonly used, that's been removed, which is DIPG and peanut. So we have to remove them, no more, okay? Ependymoma, again, 3 grades, grade 1, 2, 3. There are now 9 subtypes. We will summarize them and talk about them later. Now, starting with low-grade glioma. So again, low-grade glioma in children is pilocytic, number 1, okay? The IDH-mutant diffuse cytoma, it's rare in children, okay? So pilocytic is number 1. And it is the most common brain tumor, the low-grade glioma, including pilocytic. So it's 40% of all CNS. This is American, statistics. Below 18, 40% in children are low-grade glioma. Okay, pilocytic astrocytoma is the most common one. Remember the genetic diseases that comes with low-grade glioma, NF1, and mainly the optic glioma. Tuberous sclerosis, we have this example, SEGA. Okay, subvenous-cytoma. These come with some genetic syndromes come with the low-grade glioma. The changes in molecular and low-grade glioma is it's something new. But when we classify low-grade glioma in a clinical setting, we don't use the molecular yet. We still use the clinical classification, which is based mainly on location. Okay, then pathology. Because management of this tumor really based on their location and their pathology, whether they are pilocytic or pilomyxoid or other type. Okay, I don't want to talk much about management because the aim of this presentation is to explain or give an overview of how do we classify these tumors, how do we name them now, okay, and how do we get the final diagnosis. So molecular testing now for low-grade glioma is important in some situation, some cases where you need to confirm diagnosis. So you need to do BRAF in some tumor, and I'll give you examples to decide the proper diagnosis, prognosis. In the future, obviously, we have a rule, and these are ongoing, studies, target therapy for recurrent or resistant type of low-grade glioma, and some of them are really difficult. Okay, we'll start from polycystic astrocytoma. Majority of them in the infratentorial, posterior fossa or cerebellum, and they come in different color and shape. All these tumors are pilocytic. Okay, cystic, solid, similar to ependymoma, and these tumors are normally adherent to brainstem, sometimes difficult to resect completely. These are the easy one. They are well defined and they're separated with brainstem. They have actually a plane around them, fluid. And this is actually in the brainstem, okay? Now, the supratentorial type, and I'll give you this presentation, case presentation, to emphasize the need of having proper pathologists and proper molecular testing to confirm diagnosis, because in children, it's really important. This is an example. 11-year-old boy presented with seizure. This was one of my early cases, 2010. MRI showed this lesion, mixed density, it was resected, and the pathologist said it was anaplastic astrocytoma. Not very typical, but he insisted, and the radiotherapists gave radiation because they were told it's plastic. Now, I've been following this child and he's he's adult now, for the last 10 years, and still, this is the last MRI, no recurrence. So I always, when I follow long-term cases, and if it doesn't fit the criteria of pathological diagnosis, I always go back again and ask the pathologist, because now we have neuropathologists, ask them, please confirm diagnosis, pathological diagnosis. So the pathologist looked back again, IDH is negative, codeletion negative. She says, this is pilocytic astrocytoma. So imagine a child had pilocytic astrocytoma, treatment is total resection, and he's cured. And then you give him radiotherapy. That's why, getting proper diagnosis pathology is really crucial. Now, this is another example, supratentorial pilocytic astrocytoma coming with NF1 case, okay? This is a very interesting case that we had, just to show you what the NF1 case associated with a different type of glioma. So this is a 14-year-old boy. NF1 had all the criteria and came in with left-sided weakness. And we found a couple of lesions. So you have this deep lesion, thalamic, multicystic, some solid, some cysts, mixed density lesion. This optic pathway glioma in the orbit, and there are some signal changes in the brainstem. We thought he had also diffuse glioma in the brainstem. So this one, we tried initially, to be honest, it was purely one cyst, which we drained and then put on my reservoir. It's recollected and then came with solid components. So we went back and resect the whole thing, or majority of it. And this is latest follow-up. This was observed, it's been stable. This was given radiotherapy. So this patient is still alive. So NF1, multiple gliomas. Optic pathway glioma. Now, this is clinical entity, okay, optic pathway glioma, because the pathology could be polycytic, could be pilomyxoid, okay, and they behave really different ways. And they form about 4 to 8% of all, CNS tumor in children. And they can be in the optic nerve, orbital part, could be in the chiasm, so you'll see the supracellular, hypothalamic part, or could be diffused all over the optic tract radiation, okay? And associated in a good percentage with NF1. And if they come in with NF1, you don't need to biopsy them. Diagnosis is very clear. And they are normally they are slow growing. Some of them are more slightly aggressive. They could be associated with multiple other lesions. I've seen a couple of cases with multiple pilocytic astrocytoma, and some of them come with seeding. And so 10% of them, they might be associated with other lesions, with other pilocytic, okay, or seeding. And so this, as I mentioned, is either pilocytic astrocytoma or pilomyxoids, grade 1 or 2. We need biopsy to confirm pathology. And the molecular here, as I said, we talked about BRAF last time. So we have two kinds of BRAF. We have the BRAF fusion and the point mutation. And according to some studies, 40% of this optic pathway glioma have BRAF fusion and point mutation, and the other 40%, 20% doesn't happen. Now, this is a case that I've been following for a long, long time, and it shows you, actually, it's an interesting case because show you the natural history of some of these diseases. So this was 2-year-old when I saw him in 2010. He came with acute hydrocephalus. Shunt was done, and then biopsy is pilocytic astrocytoma. The family refused any form of treatment because the child after the shunt, he was fine. No endocrine disturbance. Vision was fine, so presumably the lesion was just behind the optic chiasm or not causing a lot of disturbance in the optic pathway. So it wasn't no major visual disturbance, and refused all sorts of treatment. The tumor keep growing over 9 years. Okay, so it's like triple in size, but the brain is still accommodating the tumor. The family is still refusing treatment because the child is fine, except from hyperactivity, and he's been referred to psychology and pediatric psychology. So this just to show you that this tumor can be really slow growing, but some of them, like this case, it can be really aggressive. 1 year old, again NF1, they have all stigmata, and she presented with encephalic syndrome. And for people who doesn't know, especially resident, they need to read about it. So the MRI showed this lesion, large supracellular lesion with CNS seeding. Biopsy was done, pylomyxoid, grade 2, and it is reported they can be associated with seeding. Started chemotherapy. So this is chemotherapy is also treatment choice, although it is low grade. Even for pilocytic, we give chemotherapy, and some of them respond well. Now, I'm showing this case because this is an example of supracellular lesion where they respond well to chemotherapy. Biopsy done. This is a 4-year-old boy, midline supracellular lesion, biopsy, pylomyxoid, high mitotic figure, radiotherapy and chemotherapy given. This is after 3 years. Good response so far, and however, he's under endocrinologist with lots of hormonal replacements and hormonal growth treatment for replacement. Okay, so this tumor, optic pathway glioma, is one of the challenging brain tumor in children because some of them can be slow growing, and you will follow them for a long time. They will have visual disturbance, endocrine disturbance, multi-clinic visits, different courses of chemotherapy, radiotherapy, and they can be, they can live with the disease with all its, side effects or consequences. And it's an area that you cannot be aggressive or resect in most of cases. This is our series that we collected for the last 10 years from different hospitals from the region, and they're all being referred to us because they are referred for chemotherapy or radiotherapy. And you can see these are the 8 male, 8 female. Range of age can be really variable. And association with NF1, 3 cases in the supracellular part, orbital, 2 of them, and 1 in the diffuse one. So a good percent of them, they are coming with NF1. This is a case of subependymal giant cell cytoma. They can be associated with tuberous sclerosis, but this child did not have tuberous sclerosis, and intraventricular lesion came in with headache, vomiting, and it was resected. SEGA, it is grade 1, and if it's totally resected, that's cured. Another example of low-grade glioma. Now, this is special entity, and that's why low-grade glioma better to be discussed in a clinical, clinically based on their location. And some of them behave differently depending on the location. For example, this one. This is rare, but when you see this in the we call them tectoplate or midbrain glioma. Interesting, they behave really, really, innocently. So they are very slow growing. Some of them be stable for years. And this is an example of case of a female girl came in when she was 2013. Obviously, they present with hydrocephalus. That's majority of their, they usually near the aqueduct, so they will block the aqueducts, and the best treatment is actually ETV, and I think ETV tried, but it failed, so she had a shunt, and the lesion's been stable for years. Okay, so for some reason, low-grade glioma in this area is, somehow it's very slow growing. This is ganglion glioma, a case of a 7-year-old boy presented with sudden onset of loss of vision with serious electrolyte disturbance. I think it came with sodium of 116. And the lesion was massive tumor, supratentorial, supracellular. So we did a biopsy first. That's what we always do with supracellular lesion, solid supracellular lesion. And it was ganglion glioma. Later on, we managed to get the BRAF, and this is example of BRAF mutation case in ganglion glioma. We tend, in a big tumor like this, is to try crash course of chemotherapy to shrink the tumor and then operate if we can. Unfortunately, we lost follow-up with this child. I think he went somewhere else. But the ganglion glioma, it's normally resection. You can always try a course of chemotherapy. This is something that's been reported in literature now. Large pediatric tumor they are very aggressive or a critical location and big. You can try always, after confirming pathology, try chemotherapy and then go back again. So in summary, okay, this is I'll just show you the different type of low-grade glioma with the percentage of mutation found in them. Okay, so for people who are interested in the oncogenesis, we can show you the different points where the alteration and mutation can happen. And this is the famous, MAP alteration, quite famous in low grade. So the alteration where the tumor start can either from the receptors and the growth factors, you can see the FGA, FGR1, then transportation to the inner membrane, this is the nucleus membrane, then the cell growth. So any point here you can get the genetic alteration, could be multiple. So this is where you see the BRAF, okay, V600 mutation, and this is the fusion, okay? This is where the MEC, and hopefully nobody will ask me about this. And you can see here different location of pilocytic astrocytoma. The fusion mutation, they found it in the cerebellar type pilocytic 25%. In the optic pathway, as I mentioned, 40%. Here in this study, 50%. Brainstem pilocytic 60%. This is good because you can give target therapy if you cannot resect the tumor. Spinal cord, 55% pilocytic. They have the fusion. Okay, but CF fossa, 80%. Deep gray matter like thalamus, 40%. Now the BRAF mutation, point mutation, V600, is only 12% in the cortical type, but very common in PXA and in ganglion glioma. Okay, so this is just a summary, the incidence of BRAF mutation and different type of low-grade glioma. So I think now we've finished with low-grade glioma. Let's move on now quickly to high-grade glioma, because high-grade glioma in pediatric population, like the low-grade, is completely different from adults. Okay, so they account for 11 to 15% of all pediatric brain tumor, between 0 to 14. Now, half of them, this is important, half of them in the brainstem and the deep midline structures, according to a lot of studies. And I'll show you our series, okay, to see how common high-grade glioma in the brainstem and midline structures. So brainstem glioma, we tend to treat them, the last, I remember, since the 60s, 70s, whenever you see brainstem glioma in a child, it's radiotherapy or adult radiotherapy. Nobody investigate them. But the last 20 years, a lot of institutes try to understand the molecular, especially when we have now the genetic alteration and the testing for genetic mutations. People try to study these type of tumor. Interestingly, I mean, they thought initially they behave like the glioblastoma or high-grade glioma in adults, but they found completely different genes and mutation. So what they found, the majority of these patients, especially in the midline, they found that they have this special gene. It's called H3 gene mutation, and they have two variants. At a point of this gene mutation, which is K27M, they found a mutation in this area, and they called it K27M. Okay, so H3K27M mutant type. It's a new entity now. It's okay, and its diagnosis is based on molecular, and I'm going to talk about it in the next few slides. At the same time, they found when they found this changes in the brainstem glioma, they expand on the hemispheric type of tumor, you know, frontal lobe, temporal lobe, high-grade glioma in kids. Again, they found some of them are different from the adult type, the IDH-mutant type, okay? And they found this group from the H3 gene, which called the G34RV. Okay, so they call the H3 G34RV mutant group. So we have now two distinctive groups. So this is not included yet, but this is something new now. Okay, it's been added to the high-grade glioma in the pediatric population. And there are more and more subtypes being found in the high-grade glioma. So we end up with four major groups which we will cover. So you can see here, this is the midline. We don't call them DIPG or brainstem glioma. It's called midline glioma. And this is the hemispheric, lobar, frontal, you know, tumors. So we have two, so we now classify them like the low grade, you know, posterior fossa, optic pathway glioma, thalamic or deep structure. We classify them into midline, non-midline, okay? Now, this is the first group now in the high-grade glioma. I mean, this is, as I said, used to call them diffuse brainstem glioma. So what they found that this genetic alteration is not just unique to the brainstem, but some of the midline tumors in the thalamus, like this example, and the spinal cord, they have the same mutation, okay, which is the H3K27M, and that's why they call them midline glioma. So it's not just brainstem, spinal cord, and thalamus, midline, okay? And they are now, it's probably the most common type of high-grade glioma. Almost half of the pediatric high-grade glioma, it's of this type, okay? So they are in this group, including midline, the cerebellum. So 80% of tumors in the midline, they are H3K27M, 80%, okay? And the remaining are the other group, which we'll show you. We found two variants of this H3K27M, the H3-1, and they only found in the pons, and the other one, H3-3, it's in the midline, so it's in the pons and the thalamus, okay? It's very important to know that these tumors, when you look at the pathology, it could be variable. I mean, this one, for example, this tumor, this is from a reference, which I'll show you later, the pathology is look like a low-grade tumor, but the mutation was present and they behave like high-grade tumor, although the pathology is low-grade. This is an example of the pathology here looks like GBM and the mutant for H3. So the point I'm trying to make here, there are pathology variation for this kind of tumor, and the molecular diagnosis is independent of pathological diagnosis. So you can see low-grade glioma, you can see glioblastoma, you can see a PXA, but once they have this mutation, we call them, and they are in the midline, we call them H3K27F midline glioma. It's a new entity, okay, and it's actually one of the common high-grade glioma in kids now. The very bad diagnosis, and nowadays, when they found them in the kids, they went back to the adults and they tried to, and when they took samples from their brainstem glioma from adults, they found this mutation present. This is an example of diffuse astrocytoma in the spinal cord, okay? Looks like low grade, but it behaved really nasty, and it was mutant, okay? Now, the other group is the other variant of the H3, the histone gene. It's G34. So we call them, actually, the easy way is we call them G34 now, mutant pediatric high-grade glioma. These are hemispheric or lobar, okay, in the temporal lobe, parietal, frontal lobe, okay. So this is an example, and they actually like in the slightly older kids. The other one, the midline one, it was younger kids, from 0 to 12. This is slightly older, and the histology is, you can get either GBM-like picture or peanut-like picture, okay? Which, I mean, this case, for example, I think before this marker, they used to be diagnosed as peanuts. Okay, peanut, we don't use them nowadays, because some of them were actually, it was found to be high-grade glioma. And they are also very poor prognosis. It's slightly better than the previous one, because you can at least resect them. Okay, so this is second common one, pediatric high-grade glioma, G34. So it's nothing to do with IDH. So it is IDH-wild-type, okay, if we can call it. It's a completely different family, the H3 or the histone gene family. Now, this is the third group, which is this is the one in adults, okay, and it's not very common in kids. So it is similar to adults. So it's a diffuse high-grade glioma with IDH mutant. So it is anaplastic astrocytoma or oligoendoglioma or glioblastoma, which is the second. And it is very rare in children. And that's why we don't see IDH mutant glioblastoma in children, because we don't see the grade 2 or 3 that will transfer later. Okay, and they are less than 6% in pediatric high grade, and they affect normally older kids, coming to teenage. Again, the prognosis here, however, is better, because you can, if you do good resection, chemotherapy, radiotherapy, their prognosis is much, and up to 5. So these are, although they are rare, but they are the best prognosis in high-grade glioma in children. The last one now is what we call them the the H3 IDH wild-type. So it's H3 wild-type, IDH wild-type. And this will include some of them, what we call the IDH glioblastoma wild-type. Again, they found a heterogeneous group of very distinctive subgroup and different glioblastoma or different high-grade glioma. So some of them, actually, interestingly, they have BXL-like group, positive BRAF mutation. Some of them in the infants, for example, they have, looks like low grade, and they have the NTRK fusion, and they are still under investigations. A lot of studies on this subgroup, which is a non-H3 IDH, or what they call them IDH wild-type or H3 wild-type, okay? So this is summary, okay, of all the high-grade glioma in pediatrics. So this is the way you need to look at the high-grade glioma in kids. Midline, hemispheric, okay? No more DIPG, so it's called midline glioma, or hemispheric. So in the midline, so majority of them, it's either HA3, this one, which, as I said, this variant can be in the pons or midline thalamus. Normally age, this is the age. The frequency is, it's common, is one of the commonest, okay? Pons midline, 5 to 10, survival is very poor. H3, K27, okay? TB53 is mutated here. Now, the other variant is only in the pons. Very poor survival, slightly younger, okay? Now, hemispheric. Hemispheric, 4 types, 4 subtypes. The G34, as we mentioned, is mainly the cortical, but the younger pediatric. Survival is poor. The IDH mutant not very common, as I mentioned, mainly cortical, and the teenage group, survival is slightly better, okay? And now this one, so IDH mutation, this one, BRAF V600, again, it's a cortical or lobar, not, it's a cortex, I mean hemispheric. Again, older kids, survival is again better, and it looks like PXA. So now this is a new group, okay? And these are the rest of it. So these are what we call the wild type. Again, it's about 30%, could be anywhere. So this is the remaining of the midline tumor. So midline, as I said, 80% this group, 20% this group, okay? And there's a lot of subgroup in studying. I'm not going to go details of this, but this will include the IDH-wild-type GBM. Now, this slide, since we've discovered now that these subgroups are also present in adults, some authorities try to classify all glioblastomas. So some authority will still call them glioblastoma, all of them, including the K27. So they still call them, you see this reference, they call them glioblastoma, okay? And they include them in all different ages. And as you can see here, this is in adults and pediatric, okay, this diagram. IDH mutant, okay, you can see the age, late pediatric, late adulthood, early adulthood, sorry, and 50s and 60s, hemispheric type IDH mutants, they call them proneural, sorry. K27, even early adulthood, okay, and they are midline, okay. This is the G34 group. These are hemispheric, again, younger, being found also in the early adulthood. This is the wild type. This is the classical wild type, okay. So this subtype, hemispheric to, I think this one is the, they used to call it the PXA similar type. Mesenchymal type, the classical IDH, which is mainly in late adult. Okay, but we couldn't, and I couldn't explain this in the previous presentation until we explain this new entity in kids. So we have now like 6 type of glioblastoma in adult, if you can accept this term, glioblastoma. Some authority will still call them glioblastoma, but some authority will say, no, high-grade glioma with different genetic variants. Now we're gonna, move quickly to, these are the cancer syndromes that come in with high-grade glioma, lymphoma, and this is interesting, okay, CMRD or DNA mismatch. I think Dr. Adlan mentioned this yesterday. This is found in high-grade glioma. I'm going to show you some examples. Okay, and then we have NF1, can predispose to optic pathway glioma and glioma. Okay, 10% of pediatric high-grade glioma can be associated with these syndromes. And we'll show you our series. So the interesting thing about CMMRD or the DNA mismatch syndrome, they have cafe-au-lait, okay? A lot of the few patients that we've seen, we thought initially they were NF1 because they have cafe-au-lait, but they turned out to be not NF1. They were patients with family history of cancer diseases, and they have cafe-au-lait, and they have other additional features which I need the president to read about. Okay, we all know about the classical features of NF1. Now I'm going to give you some case reports or presentation of high-grade glioma that we've seen. It will explain to us the behavior of some tumor. And for example, this child I've seen in 2014, bithalamic lesions, like a mirror in both thalamus, 2-year-old present with vomiting. Okay, so we didn't know what it is. Actually, I've never seen such a lesion before. We were thinking, is this tumor? So I went with the endoscope. I thought that might be the easy way. Endoscope biopsy here. And it turned out to be low-grade glioma. I said, okay, low-grade glioma, we'll give him some chemo, and because we can't resect it. And, prognosis could be good. It's a low-grade. This is obviously before the new classification. This is after a few months. The tumor progressed really aggressively, and she survived only 8 months. Okay, so at that time, and then I thought, I mean, this is not a brainstem, tumor, but behaved like a brainstem glioma. And then, these new reports that came up and, pointed out that the midline glioma, like this case, they behave like brainstem. And pathology, it doesn't matter pathology, it could be low grade or high grade, but they behave really nasty. And I wish we would have this molecular study to get the definitive diagnosis. Again, this is one of the few cases that we managed to do the H3K27. We don't have it in our center, we send it to different places, actually abroad. Our centers now, I think King Fahd Medical City, they have it now. So 4-year-old female. So there was exophytic part here, which was biopsied, just to, we could have started radiotherapy straight away, but just to be, for academic reason, I mean, we took a biopsy and it was high-grade glioma, and it was actually H3K27M. Survival 14 months, she had radiotherapy. Another example, 2015, again, we didn't know about this midline glioma. We have this lesion, deep thalamic, tumor, a 14-year-old boy. Biopsy, again, anaplastic astrocytoma. We didn't have the molecular. Again, radiotherapy, chemotherapy, survival 14 months. So again, I would include this in the midline glioma group. This is an example of the DNA mismatch case. I think this is one of the early cases that we've seen. Child, 11-year-old boy, cafe au lait spots, family history, strong family history of cancer, multiple lesion. So as just to remind you, there's no more gliomatosis cerebri now. Okay, multifocal, biopsy, again, anaplastic astrocytoma, chemotherapy, radiotherapy, survival 18 months. So this is one of the example of the DNA mismatch, or we call it the constitutional mismatch repair deficiency, CMRD. Another case that we had, again, very strong family history of cancer, 12-year-old girl. Interestingly, this girl came in 2017 with this lesion, which I operated, and it was lymphoma. I think it was B-cell lymphoma. Treated, she was fine. 2 years later, came with another lesion, posterior frontal, which was, I think she had other lesions, it's like multifocal. So I just did a biopsy actually, and it was high-grade IDH-mutant. Okay, this was just recently, this interesting case. So remember the DNA mismatch when you see a child with pediatric brain cancer which have cafe au lait, not always NF1, okay? The reason I'm saying this case, because I really want to discuss the this entity of brain tumor, the suprastellar midline lesion, how they behave differently, and the really the need to do molecular on these tumors, if we can. This is 12-year-old boy, short history of decrease of level of consciousness, tendency to sleep. Vision was fine, but there was no obvious deficit. So extensive edema, lesion in the hypothalamus. This was the lesion, marked enhancement, okay? It was biopsy was done. This is one of our colleague, Dr. Wissam Isawi, who did the biopsy in this case, and it was low-grade glioma, okay? So how did we approach, I mean, is it similar to optic pathway? Is it midline glioma behaving, aggressively because there was a lot of edema? We're not sure. And that's why, molecular is really important. We have sent it to BRAF, K27, other mutations. So molecular is really important because this child, in a few months' time, despite the chemotherapy, and I mean, I'll show you another example, child responded very well with chemotherapy. But this was with aggressive chemotherapy, the tumor continued to grow fast, and he was referred to palliative. Again, you know, I think the molecular is very useful, okay, for the subcases to get definitive pathological diagnosis and plan treatment. Another example, again, midline lesion, suprasellar. An 11-year-old boy came in with obstructive hydrocephalus, and he was referred like craniopharyngioma. So he came with obstructive hydrocephalus, and I wasn't comfortable. Look at the sagittal. I said, we'll do biopsy first, endoscopy, biopsy, EVD. And the biopsy came back as germinoma. Okay, so remember, not all the midline suprasellar lesion are, you know, optic pathway glioma or H3K27. This is after chemotherapy, 18 months after chemotherapy. So remember the differential diagnosis in midline suprasellar lesion now, okay? And this is the way I approach them, okay? If you have a child, solid tumor in the midline suprasellar, assess his vision, endocrine, check for the NF1 or caveolae, send the tumor markers for germinoma, germ cell tumor. And then if there's hydrocephalus, try to get biopsy with the EVD, endoscopy biopsy at the same time when you put the EVD. Then biopsy if it is germ cell tumor or it's just, you know, chemotherapy treatment. And you need to send all these markers if you can, if you have them, get the pathologic diagnosis. And then you can differentiate whether it's actually optic pathway glioma, it's a high-grade glioma, PXA, ganglion glioma, etc. But you need always to rule out the germ cell tumor in this location. So this is our series of high-grade glioma in kids. You have 42 patients. This was presented SANS. So again, when you look at them now, again, pediatric high-grade glioma, midline and midline. Interestingly, two-thirds of our high-grade glioma were in the midline. 1/3. So the other studies suggest 50%. So in our series, 2/3 is actually midline. We consider them as midline, and they are younger than the other group. Here it's ratio male to female 1:1. This is 2:1. Brainstem, with 80% the brainstem, 20% deep in the thalamus or deep structure. In this group, in different location, 4 of them were multiple, and we have 4 cases of query DNA mismatch. Okay, and they are still under investigation. Pathology, you can see 17, we did not biopsy them because they were clearly, you know, just diffuse pontine glioma or midline glioma. But the cases that we biopsy in the thalamus, or, you know, there's some exophytic parts, we have high-grade glioma 3, GBM2, and low-grade in some of them. Here, we have different variety. You can see one case of glioblastoma. Molecular, it's ongoing study. We're still doing the molecular. This is a future project. So if people interested in these are the target therapy for different steps in the high-grade glioma. I don't think we have enough time to show this, but this is for people interested in what we call target chemotherapy. So we target points of the you know, carcinogenetic or carcinogenesis or oncogenesis pathway. Okay, and the famous one here is bevacizumab, we call it Avastin. So this works on the angiogenesis. Imatinib is again becoming popular. Now, I'm going to move quickly because of the time. Medulloblastoma now, embryonal tumor. Embryonal tumor, we have the medulloblastoma and the non-medulloblastoma. Medulloblastoma, we have the 4 you know, molecular subtype, the 4 classical subtypes, or pathological types. NOS, again, reminder, people who doesn't remember, NOS means that we don't have the lab to do the molecular. It's called none otherwise specified. Okay, so when you see this, I mean, we didn't do the molecular. And this, unfortunately, in our center, we don't have still the molecular. We send them outside. Embryonal tumor. Now, embryonal tumor, they found this specific gene mutation, C19MC, with the multilayer rosette type tumor. And this is what we used to call them peanuts. No more peanuts. There's actually different subtypes now. And they are, majority are very rare, except this one. and ATRT. They are more common. Okay, so medulloblastoma is about 10-20% of all pediatric brain tumor. And remember the certification for risk assessment in these kids. We used to use this, you know, if there is a dissemination of disease, amount of resection, and the histology. Now we have molecular, which explain in details or in a proper way the prognostication or prognosis of these tumors. Because, for example, we have this child, and I'll give you a good example. Obviously, we present the good cases. 1-year-old boy, posterior fossa tumor in 2013, had seeding, resected, was dysplastic nodular. We didn't have any molecular. Have treatment still after 6 years. There's no recurrence. So and he was high grade because he had seeding less than 3 years. This is another example. 2 years seeding, resected. It's a large cell anaplastic. This is one of the few cases now we're sending now, and it has actually Sonic Hedgehog the type, activated type, and he just started chemotherapy. So this was 2-year-old, and this is the age of SHH or Sonic Hedgehog disease, Sonic Hedgehog. If people are interested in the pathways, there's a 4 pathway for this is the wingless integrated activated Sonic Hedgehog pathway, group 3 and group 4. Summary of this really nice slide, show you the different types. So the wingless, so we call it wingless integrated, WNT. Okay, remember, wingless integrated activated group. Sonic Hedgehog, SHH activated, group 3, group 4. So this is the least 10%, 2 type. So this one in the younger, this is above 10. Their survival is the best here. I mean, they are only 10%, but their best survival. And the case I'll show you maybe in this group, that's why they have really good survival. Although based on the old system of risk assessment, it's poor. But I think if we have done the WNT, it could be positive. They will explain the good survival. Okay, so it used to be the classical or desmoplastic Sonic Hedgehog, 30%, and now we have 4 subtypes, and depend on the age. Seeding prognosis slightly better. Okay, and this is the one we see in the younger age. Okay, Sonic Hedgehog more common in the younger kids. Group 3. Now we have 3 groups. Again, I don't want to go in details. This is used to be the extensive nodullarity or the classic. Sorry, this is a classic and large cell anaplastic. Group 4 is the most common one. Okay, and their prognosis is moderate, but group 3 is the worst prognosis. Okay, so you can see how many subtypes now for each of them. So it's becoming now like a standard, for a diagnosis to look into the prognosis and treatment. Because there's a lot of studies now on, different modality treating medulloblastoma depend on the subgroup. The non-medulloblastoma embryonal tumor, as I said, we have specific now, tumor depend on the mutation. They're not very common, they're very poor prognosis, and PNET has been removed now. So we have this entity, which is the C19MC. Again, I think a lot of the PNET and the supratentorial used to be called PNET, but they are either high-grade glioma or ependymoma. ATRT, again, it's quite common in children. It's 10-20% in children below 3. Okay, they have now a distinctive mutation. These are example of ATRT. So a 2-year-old boy we had in a hospital a couple of years ago, innocent, looking 4th ventricular tumor, and referred as ependymoma. But when we reviewed the pathology, it was actually ATRT. 1 year later, just extensive, seeding everywhere, no response to chemotherapy. Very poor prognosis, ATRT. ependymoma now. I think this is the last group. We have all these types, so it could be grade 1, grade 2, grade 3. And there's a lot of subgenetic types now of ependymoma. There are 18% for all pediatric brain tumor, different grading, 2/3 in the posterior fossa. And remember, ependymoma associated with NF2. So glioma, NF1, NF2, ependymoma. And these are the subtypes now. It depends on the location. Supratentorial, this is interesting now. This is the new entity, the RELA. I showed you one case in adult, which was published actually. RELA, they are grade 2 or 3, RELA positive. And then you have the YAP. So 3 in the supratentorial, the subependymal, which is grade 1, the balanced genome, there's not a lot of mutation. This group, YAP, it's grade 2 or grade 3. And then we have the RELA, the RELA positive. So these are RELA fusion positives, these are negative. The posterior fossa, 3 group, subependymal, again, so subependymal could be supratentorial, the posterior fossa, the grade 1. And then you have the ependymoma grade 2 or 3, and they have 2 subgenetic. In the spine, we have, interestingly, the subependymal could be grade 1, and the myxopapillary is purely in the spine, and the grade 2, 3 ependymoma. So these are all the subgenetic of ependymoma. An example of ependymoma, 5-year-old, no seeding, 2012, grade 2 radiotherapy, did well. Now this is an example, another example of a girl that we had 2 years ago, 9-year-old, presented with supratentorial lesion. It looks like a GBM actually, ring enhancing, operated. Within 2 months, the tumor recurred very fast. And we did another surgery. The pathology actually came back anaplastic ependymoma, and we sent it abroad to get the RELA because we were reporting this case, and it was RELA fusion positive. Okay, and RELA fusion positive now is very, it has the worst prognosis. It's very, it doesn't respond well to chemotherapy, radiotherapy. But it's a new entity now in the supratentorial ependymoma. Remember this RELA fusion. So this is my conclusion. Again, there are a lot of changes in glioma or other brain tumors, which residents and all of us actually has to be familiar with. And we use the new classification because now we have a new language, has to be standardized. We need to know this submolecular types if we are looking for better prognosis and treatment for this disease. And the target therapy is the future. Again, Dr. Ajla mentioned this yesterday, and this is the emphasis now, target therapy for tumor. And we can't do target therapy without studying the molecular of this tumors. And these are the references that I've for my talk. Thank you very much.
Thank you very much, Dr. Taha, for this talk. So we will conclude our webinar for today, and we'll see you tomorrow with another webinar.